Okay, with permission of our today's session chairperson, Mr. Dr. Professor Dr. Mohammed Shahudin sir. Greetings to you all. Our today's session will be on defibrillation, a very much needed and practiced uh, practiced whatever we can say that a maneuver in CCU in our everyday life of cardiologist. So I'm going in details to our today's discussion. First of all, the definition of defibrillation. Defibrillation involves delivering a high intensity electric charge in order to depolarize the entire myocardium at one time, so that the fastest normal pacemaker can regain control of the pacing function of the heart. So it is a high intensity electric charge and depolarize the entire myocardium at one time. These are the important keywords. And so the ideology is that our normal pacemaker will regain the pacing function of the heart again. There's some historical background. I always try to say something on history in my lectures, because if we don't know history and the future, we actually uh, will share like an isles in the uh, ocean. So we should know where the shores are, where we are going, where we are from. So from our previous historical background, the past was, as you all know, in 1903, the first electrocardiogram machine was invented by William Einthoven, and later on in 1924, he received the Nobel Prize for that invention. And in 1947, Dr. D. Claudebeck, Dr. Claudebeck, he was a cardiac surgeon, American cardiac surgeon. He designed, actually, he planned a defibrillator machine for use, and he was successful at that time. Initially, Beck tried with his hands only. Successfully, he massaged some diseased person, and the first reviving patient was a 14-year-old boy. With his defibrillator, he used only spoons as electrode pad. During 1980s, the first automated external defibrillator were clinically tested and put into production before 1985, when at that time the relevant scientific achievements were more great. So in electric device invention was a delayed procedure, we can say, because at that time Marty and McFly and McDonald began experimenting the space and time continuum by a DeLorean curve. At the same time, or similar time, the first implantable cardioverter defibrillator, popularly known as ICD, is invented by Michael Mirowski. The small electronic device could monitor and correct abnormal heart rhythms and was implanted on those who have suffered 2 or more cardiac arrests. Although we doubt he used plutonium and flux capacitor, that was a problem at that time. At present, in 2015, AED campaign and programs assist in the awareness of cardiac arrest and the use of defibrillator. We have an array of defibrillators and manufacturers around the world, with AEDs created with ease of use in mind, ensuring that any first responder can use a defibrillator to help save someone who has suffered a cardiac arrest, no matter what level of training they have. Everyone can use them in an emergency and provide life-saving treatment in the immediate minutes following a cardiac arrest. আমি বাংলায় বলি, এখানে এইডি গুলো এখন এইভাবে প্রোগ্রাম করা আছে যে আপনি যে কেউ, এরা বড় বড় শপিং মলে, বড় বড় বিল্ডিং এর নিচে, পুলিশ স্টেশন, আপনার ট্রেন স্টেশন, বাস গুলা, এগুলা রেখে দেয় টেলিফোন বুথের মতো পুরানো আমলে। সেখানে যে কেউ যদি যায়, সে এটা ভোট দিয়ে নিয়ে এসে এটা ইউজ করতে পারবে, এবং ওই মেশিন অন করলে ওই মেশিন আপনাকে ডিরেক্ট করবে হোয়াট ইউ উইল ডু নেক্সট। It so nicely arranged this type of defibrillator. Current statistics show that if CPR is performed and a defibrillator is used within 5 minutes of cardiac arrest, a patient's survival chances increase from 6% to 74%. This is a huge uh, amount of improvement. However, in the UK, there are over 30,000 cardiac arrests per year outside of hospital where emergency services attempt resuscitation and only 1 in 10 victims survive to be discharged. So the success rate is not so promising, but it is still showing us some light that there is a possibility, higher possibility of saving life outside hospital with the use of AED. Very few notes on defibrillation versus cardioversion. Defibrillation, as you know, that is the therapeutic use of electricity to deploy the myocardium so coordinated contraction can occur. The term defibrillation is usually applied to an attempt to terminate a non-perfusing rhythm, that is ventricular fibrillation or pulseless ventricular tachycardia. Cardioversion, in contrast, is the application of electricity to terminate a still perfusing rhythm. It is perfusing. Ventricular tachycardia with pulse, supraventricular tachycardias, including atrial arrhythmias, to allow a normal sinus rhythm to restart. By this definition, cardioversion is a less urgent procedure compared to defibrillation. Although the patient requiring cardioversion may be hypotensive or hemodynamically unstable rather than in cardiac arrest. The aim in both is to deliver electrical energy to the heart to stun the heart momentarily and thus allow a normal sinus rhythm to kick in via the heart's normal pacemaker, for example, the sinusoidal. So this is the ultimate goal, and in defibrillation we use actually high voltage of electricity, and cardioversion we use low voltage of electricity. Both are painful procedures. Cardioversion is indicated for VT with pulse, decompensated atrial fibrillation with rapid ventricular rate. For example, a hypertensive patient not responding to medical therapy, supraventricular tachycardia, atrial flutter, or it is also possibly indicated after failed pharmacological therapy for the previously mentioned arrhythmias, especially if the patient becomes hemodynamically unstable. Cardioversion should be synchronized, which means the electric current will be timed with the patient's intrinsic QRS complex to minimize the risk of inducing ventricular fibrillation. So at the top height of the QRS complex, the electricity is delivered in case of cardioversion. In case of defibrillation, there is no such option or no such timing possible. So it is forcefully given. Electricity is forcefully given to alter the ongoing rhythms of the heart. And there are another question, which one is better, AC alternative current or DC current defibrillation? An AC defibrillator is the oldest and simplest type. An AC defibrillation, a shock of 50 Hz AC frequency is applied to the chest for a time of 0.25 to 1 second through electrodes. The procedures of applying electric shock to resynchronize heart is known as counter shock. A DC shock applied without synchronization to a QRS complex is DC defibrillation. Direct current cardioversion or defibrillation can be delivered as monophasic or biphasic current. Monophasic current travels in one direction between the two electrodes. So there is another few lines. In this DC fibrillation, in this method, a capacitor is charged to a high DC voltage and then rapidly discharged. So actually, though a DC is superior and AC defibrillation is an older version of DC. Difference lies in the nature of supply. DC is safe but not as effective as AC, but we need to produce as AC because what we need to produce as a shock. DC is safer but AC is more effective. That is the controversy. Previous one is more effective but less safer, like our modern medicines. Mechanism of defibrillation. one thing we should bear in mind that it does not restart the heart. Current current that we deliver from the machine depolarize the myocardium. It momentarily stops all electrical activity, induce asystole temporarily. So everything should begin newly restart. It is though I mentioned that it is not the restart, but it is induce asystole temporarily to restart it again with synchronized normal motion. If the heart is still viable, it allows sinusoidal nodes to take over the repolarization job. Indications are quite clear-cut. It is ventricular fibrillation. Ventricular fibrillation can be converted into a more efficient rhythm by applying high energy shock to the heart. If you see the tracing, ECG tracing, this rhythm is a VF, and on that, when the DC shock is given, there is a temporary cessation of all electrical activity, and then the sinusoidal node takes over the electrical activity, normal rhythm again. This causes all muscle fibers to contract simultaneously, which may then respond to normal physiological pacemaking pulses. Ventricular fibrillation is a common cause of out-of-hospital cardiac arrest. In this case, the heart quivers ineffectively and no blood is pumped out of the heart. On the monitor, Vfib will look like a frenetically disorganized wave line. Ventricular fibrillation may be fine or coarse. Coarse ventricular fibrillation is more likely to convert after defibrillation than fine Bfib. Fine Bfib is sometimes mistaken for asystole. As the treatment of asystole and ventricular fibrillation are different, it is important to differentiate between the two. If in doubt, it is acceptable to deliver a shock. If it is fine Bfib, you may terminate the rhythm. However, if the rhythm is asystole, defibrillation will be ineffective, and you can follow the asystole protocol with confidence. So, in a nutshell, coarse ventricular fibrillation is more convertible than fine ventricular fibrillation. Fine ventricular fibrillation make confusion with asystole. If we are not sure, we can give the shock, and if we are sure that it is asystole and with shock it is not reversible with fine Bfib is not reversible, then we can follow the protocol of asystole. This is a pulseless ventricular tachycardia. TV sound is the same. Indications of ventricular tachycardia typically responds well to defibrillation. This is more responsive than ventricular fibrillation. This rhythm usually appears on the monitor as a white, regular, and very rapid rhythm. Ventricular tachycardia is a poorly perfusing rhythm. Patients may present with or without a pulse. Most patients with this rhythm are unconscious and pulseless, and defibrillation is needed to reset the heart so that the primary pacemaker, usually the sinusoidal node, can take over. Multiple shocks may be needed, but good compression and adequate ventilation are also important. These are the two things: good compression and adequate ventilation. If defibrillation is not helpful in terminating the rhythm, it is necessary to investigate possible causes, as treatment will likely fail unless the underlying causes is identified and treated. And the third indication, when unsure whether monomorphic or polymorphic VT in an unstable patient, we can use it. DC versus AC Defibrillation-Summary. Actually, these are the indications, not the DC versus AC Defibrillation. This is a pulseless polymorphic VT or VF when unsure whether monomorphic or polymorphic VT in an unstable patient, not in a stable patient. Defibrillation is not indicated for asystole pulseless electrical activity. Also contraindicated for sinus rhythm, a conscious patient with the pulse, or when there is a danger to operator or other from a wet patient or wet surroundings. And now I am going to the part of defibrillator machine. Machine itself is a part. then the pedal, ECG printout, alarm knob, and synchronizer. The defibrillator have so many varieties nowadays to cover all the situation demanded places. First of all is automated external defibrillator used in public places, semi-automated external defibrillator used by paramedics, standard defibrillator with monitor, monophasic or biphasic, which we are using in CCU, transvenous or implantable cardioverter defibrillator, that is ICD, and wearable cardiac defibrillator, which is wearable like a jacket. These are some photos of manual external defibrillator, and the monophasic waveform and the biphasic waveform. Here you can see between two pedals, the current delivered in one direction in monophasic one and the current delivered in two directions in biphasic one. Advantage of biphasic over monophasic. Biphasic uses less power, so less trauma will occur, less battery will be used. Defibrillation more effective at low energy. Fewer burns, less myocardial damage. First shock success rate in cardiac arrest due to shockable rhythm in case of monophasic is 60%, in case of biphasic in case of 90%. So it is more advantageous, and all the machines are built in with biphasic use nowadays. And now about ICDs. An ICD is a battery-powered device placed under the skin that keeps track of our heart rate. Mechanism, how it works. If heart rate is too slow, device detects it and works as a pacemaker, restore normal heartbeat. If heart rate is too fast or chaotically slow, device detects it and gives defibrillation shock, restore normal heartbeat. It works 24 hours, 7 days. Indications of ICD. Mainly for secondary prevention, it is a summary of the indications. The patient who have survived prior cardiac arrest is a candidate for implantable ICD. Sustained BTBF in patient with structural heart disease or in case of MI within the 40 days, more than 48 hours after an MI setting, in the absence of ongoing chest pain. Syncope caused by ventricular arrhythmia. This BTBF, if it causes syncope, then it is also indicated. Primary prevention. Individuals at risk but who have not had a documented episode of cardiac arrest. In case of this situation, that is, no patient have not any episode of sustained BTBF or arrhythmic syncope. Still, we can use as a primary prevention that will be benefit the patient in case of inherited arrhythmia syndromes, hypertrophic cardiomyopathies, arrhythmogenic right ventricular cardiomyopathy, non-hospitalized patient awaiting cardiac transplant, sarcoidosis, giant cell myocarditis, and Chagas disease. There are some contraindications of ICD. Not recommended in secondary prevention, though it is recommended in most cases of secondary prevention. There are a few exceptions. That are completely reversible cause of BT and VF. That is, electrolyte abnormality, drug, trauma, or VT amenable to cure with ablation. These are the contraindication. VT-VF within 48 hours after diagnosis of MI. So VT-VF after 40 hours, within 40 days, it is an indication. But before 48 hours, it is a contraindication. This is a picture of wearable cardiac defibrillator. It wears, patient can wear it like a life vest. Now a few things about pedal placement. We use usually 4 positions: anterolateral, most convenient, anteroposterior, anterior and left infrascapular, and anterior and right infrascapular. Anterolateral is the most convenient, and we frequently use this. Anterolateral position, one in the right of the sternum below the clavicle, second or third ICS, and other is left, fourth or fifth ICS, mid-axillary line. That is at the apex, and right one is on the sternum below the clavicle. The reversing pedal marking sternum and apex does not affect. These are not actually. You can alternate the pedals. Which one is? It is not fixed for apical position or sternal position. Pedals placed along the long axis of the heart. AP placement used in children with adult pedals. It can be used in children also. So there are some pictures of placing the pedals. Pedal size, adult size is larger and pediatric size is smaller. There are some varieties. And nowadays pedals, instead of pedals, we like to use adhesive patches. Pedals need significant levels of force, which is not needed in adhesive patches. Adhesive patches allow good ECG tracing without interference. Adhesive patches safer as no need of operator, no mess with gel. So adhesive patches replacing nowadays the pedals, traditional pedals. Delivering the levels of energy by the defibrillation. Energy level in case of monophasic machine, it delivers 360 joule. In case of biphasic, it initially delivers 150 to 200 joule and subsequently 150 to up to 360 joules. Steps of defibrillation. First, 2 minutes of CPR before analysis. We have to analyze, we have to send the blood samples, we have to set the all necessary lines. So in between the defibrillation and receiving the patient, 2 minutes CPR is recommended. So power given to the machine, attach the electrode pad, check the rhythm, then clear all. We should clear the site. Give the shock. Initial shock is 120 to 200 joule. Resume CPR for 2 minutes before analysis cardiac rhythm again. Consider giving vasopressor, antiarrhythmic drugs, subsequent shock. You can give vasopressor if it is restored. You can give antiarrhythmic or you can re-shock the patient. There is a mnemonic, that is a word coached. Coached for chest compression, C for chest compression, O for oxygen away. Oxygen cylinder should be taken away. Oxygen line should be taken away. All else clear. Charging, hands off. Evaluate the rhythm shockable versus non-shockable rhythms. You should always check before delivering the shock whether it is shockable or non-shockable rhythm. Then we should defibrillate the patient. There are some after procedures. Without this after procedure, the total procedure will not be successful in many cases. Monitor that patient stay in the converted rhythm. Keep patient well oxygenated. Check serum potassium and magnesium level. Maintain acid-base balance. Get 12-lead ACC after procedure. Check for chest pain and excess. Get CPK and troponin done. Access patient skin. Causes of failed defibrillation. Poor patient condition in case of structural disease, valvular heart diseases, massive MI, cardiomegaly, myocardial rupture, cardiac tamponade, pulmonary embolism, infarction, respiratory disease or trauma. These are all poor patient condition causing failed defibrillation. Prolonged cardiac arrest is another cause. Inadequate cardiorespiratory resuscitation measure due to hypoxia, acidosis, electrolyte imbalance, drug toxicity, inadequate sympathetic tone. So we usually send the blood sample to analyze these underlying conditions. Inadequate electrical current delivered to the heart, defective equipments, poor pedal position, excessive conductive jelly between the pedal chest, inexperienced operator in last. The procedure will not be secured and successful if the safety precautions during the defibrillation is not properly maintained. Ensure no one is touching the patient and nothing is connected to them when shock is delivered. Temporarily remove oxygen mask 1 meter from the patient. If a self-inflating bag with oxygen attached is connected to a tracheal tube, it is not necessary to disconnect it. Wear gloves, which may provide a degree of protection from an accidental shock. Complication of defibrillation. Most Common complication is skin burn, myocardial necrosis with high voltage, cardiac arrhythmias like asystole, VF, pulseless electric activity, and other less serious arrhythmias are more common. We should always consider for a successful defibrillation that during ventricular fibrillation, if the longer ventricular fibrillation lasts, the harder it is to cure. The quicker the procedure starts, it is better. Shock early, shock often. Likelihood of resuscitation decreases by 7 to 10% with every passing minutes. Myocardial environment, hypoxia, acidosis, hypothermia, electrolyte imbalance, drug toxicity, and as we mentioned earlier, do not delay shock trying to correct these problems. We should shock the patient first. Then, if it is a simultaneous process that we will send our sample. Heart size and body type. Pediatric requirement lower than adults. Direct size energy relationship in an adult is actually unknown. Use larger size pedals. Completely contact chest without pedals touching each other. In pediatric, minimum of 3 cm distance between pads should be maintained. Small pedals concentrate current, burn hard. Large pedals reduce current density. So, large pedal size is more patient friendly. And we should monitor, as I mentioned previously. And defibrillation success, it is our success when all these procedures are appropriately taken. Termination of VF into an organized rhythm or asystole for at least 5 seconds after shock, regardless of hemodynamic response, is cause defibrillation success. That is termination of VF into an organized rhythm or asystole. That is also asystole for at least 5 seconds after shock. That is probably because that we successfully delivered the defibrillation current, but the rhythm is not still back to the normal, but it is on the way probably, and we can reshock the patient. Start with lower Joule first, 150 to 200 Joule biphasic truncated waveform, and 120 for biphasic. These are complicated terms, so clinicians should not know this, but we always, this is a thumb rules that we should try to deliver the current as low as possible. Key points: biphasic waveform cardioversion is safe and equally effective as monophasic cardioversion, using much lower energy with reduced post-shock complications such as cardiac dysfunctions, dizziness, and skin burns. Defibrillation or unsynchronized cardioversion is indicated in any patient with pulseless VTBF or unstable polymorphic VT where synchronized cardioversion is not possible. Synchronized cardioversion is utilized for the treatment of persistent unstable tachyarrhythmia in patients without loss of pulse. Amongst this category, AF remains the most frequently encountered one. In critically ill patients, unstable supraventricular tachycardia benefit from individualized therapy such as inotrope and vasopressor support, antiarrhythmic medication, and mechanical ventilation, and not necessarily electric cardioversion as the first treatment. In case of unstable supraventricular tachyarrhythmias, there is a lot more things to do before giving a shock. It is important to become familiar with the cardioversion device available, the appropriate energy setting, and the correct placement of the pedals to ensure effective and timely shock administration. It is our future. So we are from past, present, and now our future. Scientists think that beams of red light could restore normal heartbeat functions in humans, replacing the use of painful electric shocks. Researchers have already tested this on animals and hope to make incredibly an optical defibrillator. We are on the way of inventing a optical defibrillator using red light. Biomedical engineering professor Natalia Tryanova, based at Johns Hopkins University, said that with this technology, light will be given to a patient who is experiencing cardiac arrest and we will be able to restore the normal functioning of the heart in a gentle and painless manner. A team from Germany's University of Bonn tested mouse hearts whose cells had been genetically engineered to produce proteins that could be triggered by light. Once second light pulses were all that was needed to restore a regular heartbeat. Scientists at Johns Hopkins then designed a human heart sim, like mobile sim, noting that the blue light used by the German team on the smaller mouse hearts wasn't strong enough for human heart tissue. Red light, with a longer wavelength, like our infrared used in pointer we use and the remote controls, was more effective, at least according to their computer simulation. Optical defibrillators aren't coming anytime soon. It will still take around 5 to 10 years before the technology is ready for human patients. And there are some proposals. In Japan, there are flying drone defibrillator are on the way, and these are all for patients' benefit. And in the UK, there are some interesting conversion of technology. In the UK, there are number of old telephone boxes which have been converted to house defibrillator, especially in small town and village locations, where residents have pulled together to provide their home with life-saving equipment. So in our country, there were a lot of telephone booths at one time. These are nowadays obsolete, but UK is utilizing these telephone booths for delivering the defibrillation. Thank you for being an active part of this presentation. And now I am handing over to our beloved sir to say something about today's topic. And any question you can ask me, and sir will try to solve the question.
Thank you, sir, for your nice presentation, sir. Sir, I have a question, sir.
Yeah.
স্যার কার্ডিয়াক অ্যারেস্টের পর আমরা স্যার দেই ডিসি শক দেই। এখন স্যার আমরা একবার দুইবার তিনবার বাট কতবার পর্যন্ত মানে দিতে পারবো, এটা কোনো আইডিয়াল নিয়ম আছে কিনা যে এতবার পর্যন্ত শেষ?
এটা সম্ভবত আমার মনে হয় প্রশ্নটা এখানে জি এরকম কোনো লিমিট আমার
তিনবার স্যার
তিনবারের কথা ঠিক আছে, তিনবারেও যদি কারেক্ট না হয় যেটা সে বলতেছে আর কি।
কতক্ষণ পর
না কতক্ষণ পর কতক্ষণ পর্যন্ত দিতে পারবো আমি?
তিনবারেও যদি কারেক্ট না হয়
আমরা দিব, তো দেওয়ার পরে তো আমরা সিপিআর দিব 2 মিনিট, তারপর আবার রিএসএস করব। রিএসএস করে যদি মানে আবার শকেবল হয় আবার শক দিব, এভাবে আর কি 3 বার 3 সাইকেল।
3 বার দেওয়ার পর যদি না হয় তাহলে আমরা মানে আর দিব না, এই তো?
এখন এখানে বিষয়টা হলো আপনি ভিএফ কে ধরেন কারেক্ট করতে যাচ্ছেন, 3বার দিলেন কারেক্ট হলো না, তাহলে কি হইতে পারে? আইদার it will create a asystole, or the VF is not, in that case it is an asystole, or it is a non-shockable rhythm due to other underlying cause. So আমরা যদি আর্জেন্টলি ব্লাড রিপোর্ট গুলো যেটা বিদেশে হয় আর কি, সাথে সাথে অ্যানালাইজ দিয়ে ওরা বাইর করে ফেলে, সেরকম কিছু হয়, তাহলে আপনি ওই দুইটা লাইনে ভাগ হয়ে যাচ্ছেন। আইদার অ্যাসিস্টল প্রোটোকলে আপনি চলে যাচ্ছেন, অথবা নন শকেবল কোনো কজ আছে কিনা সেগুলোর কারেকশনে চলে যাচ্ছেন, তাই তো? আর 3বারের পরে দেয়া যাবে না এই কথাও কিন্তু কোথাও বলা নাই। 3বারের মধ্যে যেটা কারেক্ট হয় না সেটা বুঝে নিতে হয় যে আমাদেরকে এটা আসলে আমরা এই সঠিক রাস্তায় নাই। বিষয়টা সম্ভবত আমাদের উপরে ছাড়া আছে, কিন্তু কোথাও হার্ডলি এরকম বলা পাই নাই যে 3বারের বেশি দেয়া যাবে না।
জি স্যার।
স্যার থ্যাংক ইউ স্যার ফর এক্সিলেন্ট এন্ড ইলাবোরেট প্রেজেন্টেশন স্যার। আমার একটা স্যার কোয়ারি ছিল স্যার।
জি বলেন
স্যার। মানে আমরা যে এমআই এর পরে স্যার যখন বিটি হয় পেশেন্টের, আমরা তো মানে ডিফিব্রিলেশন দিয়ে এটাকে কারেক্ট করি স্যার। কারেক্ট করার পর স্যার আমরা মেইনটেনেন্স হিসেবে স্যার ওই যে ফার্মাকোলজিক্যাল ড্রাগস যেমন এমিউডারন চালু করি স্যার। এখন আমার কোশ্চেনটা হচ্ছে স্যার, আমি এই এমিউডারনটা কতক্ষণ চালাবো এবং এটার পরবর্তী লং টাইম মানে স্যার মেইনটেনেন্স হিসেবে কি আমাকে ওরাল দিতে হবে কিনা, বা এটা কিভাবে স্যার মানে মেইনটেনেন্স কিভাবে করবো স্যার?
এটা আমার স্যার আপনি ভালো বলতে পারবেন, বলেন
স্যার। আমার এটা
আচ্ছা, এমআই পরে আমরা ডিফিব্রিলেশনের যে প্রোটোকল এটা বলছি, কিন্তু দেখেন
জি স্যার, ওটা ঠিক আছে।
উইদিন 40 আওয়ার্স এর মধ্যে আমরা দেই না, কারণ এখানে তো আমাদের কিছুটা ইয়েও আছে, ওই যে রিপারপেশন ইনজুরির বিষয় আছে, এইগুলা বিষয় আমাদের অনেকগুলো বিষয় আছে সামনে, এখানে আমরা ডিফিব্রিলেশনে যাই না। কিন্তু
স্যার উইদিন 48 আওয়ার্স আইসিডি দিব না, ওইরকম হলে আইসিডি হবে না, কিন্তু
আইসিডি
যদি স্যার
না, ডিফিব্রিলেশন আপনার লাগলে দিতে হবে, আপনার যদি
ডিফিব্রিলেশন দিতে হবে,
ডিফিব্রিলেশন দিতে হবে। এখন ওই ডিফিব্রিলেশন দেওয়ার পরে মেইনটেনেন্সে কিন্তু দুইটা কথা বলা আছে, আপনি ড্রাগ দিয়েও মেইনটেইন করতে পারবেন, আবার যদি প্রয়োজন হয় আপনি দিতে পারবেন, তাই তো? এখন কারেকশন হওয়ার পরে আমরা তো আইসিইউ সেটিং এ আইভি দিচ্ছি পেশেন্টের যতক্ষণ লাগে। আপনি যখন মনে করতেছেন পেশেন্টটা স্টেবল, both electrically and biochemically stable, দেন আপনি কি আর আইভি কন্টিনিউ করবেন? পেশেন্টকে কি প্রয়োজন ছাড়া রাখবেন? অনেকদিন রাখবেন না। দেন ওরালি ইউ ক্যান গিভ। এখন প্রশ্নটা হচ্ছে ওরালি কতদিন দিবেন, এই বিষয়টা আই এম নট ক্লিয়ার। এটা আপনারা একটু স্যারের কাছ থেকে জেনে নিতে হবে, আমরা ক্লিয়ার না।
Thank you, sir, for your nice presentation. I want to ask you a difference between monophasic and biphasic.
Very simple. It is the direction of current flowing from one ped to another. If it is flow one ped to another directly and not come back again, it is monophasic. In one direction current flows, and in biphasic it goes from one lead pedal to another pedal, or one lead to another lead, and come back, and it is going on like a cycle of current.
মানে স্যার monophasic বলতে স্যার বাংলায় যদি বলি যে ফ্লো অফ কারেন্ট একদিকে থাকবে, আর
একমুখী দ্বিমুখী।
জি স্যার, জি স্যার।
আচ্ছা, দ্বিমুখীর সুবিধা হচ্ছে যেহেতু একই কারেন্ট ঘুরে ঘুরে আসতেছে, আপনার ডেফিনেটলি এখানে আপনার কারেন্ট ইউজটা আমরা কমাই দিতে পারি, সো ইনজুরিটা কম হবে, স্কিন ইনজুরি কম হবে, মায়োকার্ডিয়াল ইনজুরির চান্সটা কম থাকবে,
ফিব্রিলেশন কারেকশন ভালো হবে,
ভালো হয়।
থ্যাংক ইউ স্যার।
স্যার এখানে একটা কোশ্চেন ছিল স্যার, একটা টার্ম ছিল পারফিউজিং রিদম আর নন পারফিউজিং রিদম স্যার, এটা বলতে স্যার
ওই যে আমরা যেটা বলি ক্লিনিক্যালি যেটা বলি পালসলেস, প্যাথোলজিক্যালি ওইটাই নন পারফিউজিং, একটা ক্লিনিক্যাল একটা প্যাথোলজিক্যাল।
ও থ্যাংক ইউ স্যার।
কামাল
স্যার,
স্যার তো স্যার বোধহয় বিজি আছেন নাকি?
স্যার আমাকে হোস্ট বানাই দিয়েছেন,
তাহলে আমরা মনে হয় যেহেতু স্যার বিজি আছেন, আমরা কি আর কোনো প্রশ্ন বা আলোচনা থাকলে করি, নাহলে শেষ করে দিতে পারি?